Now, we are continuing our lecture with the epilepsy. Today we'll go into detail, right? We'll talk about that, what are the different types of epilepsy, what are their causes, what are the triggering factor, what are investigations, and how you make up your diagnosis, and eventually how you manage the patient in simple epilepsy and medical emergency, which is called status epilepticus. Now, how we are really defining epilepsy? Epilepsy is the tendency for spontaneous recurrent, especially recurrent seizures due to abnormal electrical discharge in the central nervous system, right? Now, primarily we divide, there are so many ways to classify epilepsy, right? We will go with one of the simple way, right? Epilepsy can be divided into partial epilepsy, right? Then we can talk about, yes please, generalized epilepsy, and of course then there are, okay, in between them there is another funny thing which is called partial becoming generalized, partial epilepsy which becomes eventually becoming generalized. First of all, we'll talk about partial epilepsy, then we'll talk about partial cases which become generalized, and then we'll go into detail of generalized epilepsy, and some people say there are some cases which cannot be classified, right? Now, first of all, we'll concentrate on the partial epilepsy. Actually, let's suppose here is your central nervous system. Now, one thing which is very important to understand that, here are thalami, and thalami, through the thalami, here is what? Reticular formation, and through the thalamic intralaminar nuclei, there are connections which are going throughout the central nervous system. Let me make this diagram more clearly. All of you know that there is reticular formation present in, yes please, brainstem, and here it is thalamus at the top of the brainstem, and from reticular formation, a lot of ascending pathways are going to these nuclei. These are called intralaminar nuclei of thalami. Now, these ascending fibers which are going to this area, right, they are distributed to all cerebral cortex, and these fibers are responsible to activate all the cerebral cortex. Now, here I want to make one concept very clear, that what really happens when you are sleeping, listen carefully, when you are sleeping, can you hear what is going on around you? Usually not. Or if you are sleeping really, you are having a sound sleep, if there's little bit light, do you see that? Okay, if you are really sleeping and someone opens your eye, but you are sleeping with a very sound sleep, put a photo of a very beautiful lion, can you really see that? It means your eyes are having something wrong? No. If someone is talking and you are really sleeping deep, you cannot hear, but do you think your ears are okay? Yes. What really happens? Who really sleeps? These are not the eyes, these are not the ears. What really sleeps is your cerebral cortex. What really happens that during the sleep, if someone is talking, actually ear is stimulated, of course drum is stimulated and ossicular chain is stimulated, cochlear duct start making microphonic potentials, cochlear, and from there cochlear nerve take the action potential to the cochlear nuclei, and through the ascending pathways, action potential really travel. What happens when action potential go to the, which part? Auditory cortex. Auditory cortex does not process them because it is at low metabolic situation. Is that right? So, in the same way, if you are sleeping and someone shows you some photo, you don't see that. Actually, still eyes may be okay. All the action potentials are going to cerebral cortex in the which area? Occipital, right? Area 17, 18, 19. But those areas are not working and processing the information. So what we are talking about, when you really sleep, who is sleeping? Cerebral cortex, because that is the seat of consciousness, especially frontal and temporal cerebral cortex, right? Now, in the morning, what happens? you wake up. Actually, who wakes up? Cerebral cortex. But who makes the cerebral cortex to wake up? Right? That is your reticular formation. There are many other areas also, but what really happens that all the ascending information which is going, sensory information, it has collateral with the, what is this area? Reticular formation. In the morning when any stimulus come, if reticular formation has come out of its exhaustion and it has developed a good concentration of, you can say, neurotransmitter, during the night when you were resting, reticular formation was gradually increasing more and more neurotransmitters, and it becomes more sensitive to sensory input. So by the morning, even little sensory stimulation, maybe auditory stimulation, visual stimulation, or even someone little touch, you may wake up. How you wake up? This is the main switch of central nervous system, because reticular formation start giving action potential to the ascending pathway that stimulate intralaminar nuclei. Intralaminar nuclei shoot up and fire up to the all cerebral cortex. When all cerebral cortex become active, you wake up. How? When frontal cortex become active, you start thinking consciously. When motor area become active, you can consciously move. When sensory area become active, so touch, pain, temperature can be perceived. When parietal areas are activated, your memories come to the surface. When occipital area becomes active, you can see the things. When temporal area become active, you can hear the things. So what really happens? First thing which you have to be very, very clear, the seat of consciousness is from where? Reticular formation to the intralaminar nuclei of thalami, and then projection to the all cerebral cortex. To all the day you work, right? And eventually, at when the time of sleep comes at night, what really happens that neurotransmitters start exhausting here, and they are unable to keep the whole cerebral cortex activated, and then you start feeling sleepy. Is that right? And usually, if you really want to sleep, you cut off all the sensations. You don't want to see light, you don't want to hear anything. You make an environment which is very conducive so that minimum stimuli come to your central nervous system, and then reticular formation become slightly, that part of the reticular formation which is supposed to keep the cerebral cortex active, that become off. So intralaminar nuclei become off, thalamus become off, this part of thalamus, and cerebral cortex activity become minimal, and you are then not aware of self and the surrounding, but you can be aroused with appropriate physical or other stimuli. Is that right? So we call you are in a state of sleep. Now what is the relationship of all this basic information with the epilepsy? Let me tell you what is the relationship. Actually, in any type of epilepsy, if epilepsy involve these ascending pathways through the thalami, you know, thalami are the part of telencephalon or diencephalon? Thalami are part of diencephalon. Is that right? So what really happens that any type of abnormal electrical discharge in the central nervous system, if it involves both thalami, it will alter the state of consciousness, because it interrupts the normal ascending system which keep your cerebral cortex active, right? And when your cerebral cortex does not remain active, we say state of consciousness is altered. So it means that when I say there is a patient who is suffering with epilepsy and his state of consciousness is altered or he becomes unconscious, it means both diencephalon are involved. Thalamocortical pathways are disturbed. Is that right? And they are unable to keep the cerebral system into normal awakening state or normal conscious state. But if I talk about another patient of epilepsy, that he has epilepsy, but during the epilepsy he maintains his state of awareness and consciousness absolutely normal, it means that epileptic form focus is not involving this ascending system. So today onward, there is a very basic concept that epilepsy patient can be divided into two types, right? The patients which really have altered consciousness during the seizure, and patients who do not have altered consciousness during the seizure. What is the real difference? The patients in which altered consciousness is present, it means thalamocortical pathway or diencephalon has been involved by the abnormal electrical activity, right? But when we say that someone has epilepsy but state of consciousness is not altered or patient does not become unconscious, right, we say that diencephalon has not been involved. right? So next time it's very simple in your life, in any MCQ or any way you find that if a patient during seizure become unconscious, diencephalon is involved. If during any type of seizure, whatever the type, if patient does not become unconscious, what happens? Diencephalon is not involved. Is that clear? After having this basic information, now we come to the concept of partial epilepsy. Now look, let's suppose here is a patient. I'm just giving you an example. Let's suppose in this patient we start stimulating this area electrically, or there's abnormal electrical focus in this area, and this abnormal electrical focus overfires. First again I will go to physiology. Listen. For example, if I want to move my thumb, what I'm doing? That upper motor neurons which are controlling the thumb, which are present in motor cortex, they are firing down and then stimulating the lower motor neurons which are going to move the thumb. Is that right? Now, what really happens when I'm moving the thumb, and if I want to move only my thumb, do you think automatically my all arm will move or not? It will not move. Why? Because normally in the central nervous system, there are very effective mechanisms to prevent the undue spread of electrical current. There are millions and millions of circuits in the central nervous system. You know, with the most modern criteria, you make a computer which has equal circuits of one human brain. Size of the computer may be equivalent to England. Human brain has so many connections. Is that clear? Now, the thing is that when you are doing some selective action, I'm just moving my thumb. It means there's some localized area in the central nervous system, in the motor area is firing. But do you want that if I want to move only my thumb, do you think current should spread to the area of the arm and then to the leg and all my body start moving? It should not happen. Actually, in central nervous system, there are very wonderful mechanisms which can stimulate a certain part of the central nervous system, and there are equally wonderful mechanisms which prevent the undue spread of the current to the other remaining circuits. Now, write it down. The basically stimulatory system is cholinergic system, glutaminergic system, and a spartate system. There are many others, but cholinergic systems, glutaminergic system, and spartate system are usually stimulatory systems, neurotransmitters in the central nervous system. And main inhibitory system in the higher nervous system is, dopamine somewhere stimulates, somewhere inhibits, so I didn't talk about that. Main inhibitor is GABA, gamma-aminobutyric acid. GABAergic system in the spinal cord, even glycine can act as an inhibitory, but we are right now talking about epilepsy, and epilepsy usually takes origin from the upper part of the brain. So in upper part of the brain, the most important inhibitory system is GABAergic system. Now what really happens? Look, this is a very funny thing. If this is the star, this is the area, group of neurons, when these are stimulated, my thumb will move. As soon as these fibers are going down, on the side they stimulate the GABAergic system. They stimulate GABAergic system. And all the cortical areas and neuronal circuits which are around the stimulated focus, they become inhibited. Some of you must be knowing when GABA bind with its receptor, it loads the neuron with chloride. So that neuron become more electronegative, so that it become hyperpolarized and it become difficult to stimulate that neuron. Is that right? Or some GABA receptors, when they are stimulated, neurons release potassium. And when neurons release potassium, again neurons become hyperpolarized. They are GABA A receptors, they are GABA B receptors. When GABA A receptors are stimulated, neurons get loaded with chloride and neurons become hyperpolarized. Or when GABA bind with GABA B receptors, neurons become deloaded of potassium and again neurons become what? Hyperpolarized. So GABA A or GABA B receptors, whenever they are stimulated by GABA, they lead to inhibition of the neurons. Now the point which I told you right now was what? That whenever in the cortex there is some electrical activity going on selectively, it has recurrent connection, so that when one area is firing, automatically it leads to inhibition of the surrounding area, so that the electrical activity remain selective. Is that right? Now, let's suppose, attention please. Normally central nervous system work in this fashion. That whenever any area is stimulated, surrounding area should get inhibited, so that there should not be undue spread of electrical current. Is that right? Now, in many patients who have especially epilepsy due to idiopathic reasons previously called, they have some defect in their either stimulatory system, either stimulatory system was over functioning or inhibitory system was under functioning. Epilepsy is abnormal electrical discharge in central nervous system. The cause of abnormal electrical discharge may be that the neurons patterns you have inherited, which are cholinergic or spartate releasing or glutaminergic neurons, either those circuits are over functioning and they function so much at times that GABAergic system cannot keep the surrounding, cannot keep the undue spread inhibited, or some people have inherited GABAergic system which is weak. What I really mean? That if you get a car from Toyota company, either it is inherited defect from the company in the accelerator and accelerator overworks, or there is inherited defect in the biological brakes and they don't work. So this is the basic problem, abnormal electrical electrophysiology in epilepsy, that either stimulatory system is overworking or inhibitory system is underworking, or in some very unfortunate patient, both problems may be there, right? Now, imagine, let's suppose we talk about a patient in which GABAergic system in the central nervous system is weak. When GABAergic system in central nervous system is weak, what really happens? When an abnormal, once an area start firing, current will spread, undue spread of the current will be inhibited or not? No. So what really happens? If someone has weak GABAergic system, there will be, sometimes when some part of the CNS is stimulated, there will be undue spread of the electrical current. Now, how much this current will spread, it depends on a particular patient to patient. When this undue current starts spreading, right, we say a large areas of central nervous system fire synchronously. Large areas of central nervous system fire synchronously, right? So usually in epileptic focus, what is going on there? The repetitive synchronous discharges, train of action potentials coming from particular area which is not kept inhibited properly. Am I right? Now, again, now listen very carefully. Let's suppose in this particular patient, this area is, whenever it fires, GABAergic system around it is not working well. So it means that there will be undue spread. When there will be undue spread, now, if this undue spread involve the diencephalon, patient will have, altered consciousness or unconsciousness. But if it does not involve diencephalon, patient won't have any alteration of conscious level. Is that right? This is one thing. Secondly, when current abnormally spread, in some people there is a partial spread. For example, spread start from only small area, there is abnormal spread and may remain limited to one hemisphere. If there is abnormal spread and it remains limited to one hemisphere and it does not involve the other hemisphere, this type of epilepsy is called partial epilepsy. So from today onwards, what is partial epilepsy? Partial epilepsy is a type of epilepsy in which onset of the seizure, which may be motor experience or sensory experience or psychomotor experience. Partial epilepsy is a type of epilepsy in which onset of the seizure, right, in which onset of the seizure is referable to one hemisphere, maybe right cerebral hemisphere or left cerebral hemisphere. For example, look here. Let's suppose I'm standing like this. Suddenly this start showing abnormal motor movements, right? And these abnormal motor movements are due to abnormal electrical activity in the left hemisphere. Of course, this is my right hand cross connected, right? Now, if this electrical current does not spread much, only their hand will show some abnormal electrical activity. After some time, discharge become normal. Now, this was a sort of a motor epilepsy, but the onset of this epilepsy could be referred to one hemisphere. So it is considered partial epilepsy. It was motor epilepsy, it was partial epilepsy, and during this if I remained fully conscious, then it was simple epilepsy. It was simple epilepsy, right? It means epilepsy you have to see. But opposite to that, imagine, let's suppose my hands start moving like this and then I become unconscious. What is this? First of all, it was partial because this head was moving, other was not. So it means onset of the attack was referable to one hemisphere. Is that right? So what we'll call it? It is partial. But with that, I had altered consciousness. So it means it is complex. So it means when diencephalon is involved, case become complex. When during an attack of epilepsy, if altered consciousness is present, right, it means diencephalon is involved, it means case becomes complex. But if diencephalon is not involved, then case remains simple. So when a patient of epilepsy comes, you have to see that is it partial epilepsy or generalized epilepsy? Is it simple epilepsy or complex epilepsy? And is it motor epilepsy or sensory epilepsy or psychomotor epilepsy? Now let's talk clinically. Attention please. The first case, when a patient is brought to you, is about the seizure. The very first question is, what is that? Yes, who is? No, you have to talk in English. Listen. A patient is brought to you and relatives think or history suggests something as if patient has a seizure. And if patient has more than one attack, you start thinking in the line of epilepsy. The very first thing which you have to make clear in your mind is, okay, you have to talk to witness if it is there, because witness is very important. But remember, many witnesses are not reliable. Many people are so polite that they want to agree to whatever you want to ask them and bring out of them. But you have to be careful that witness should be dependable, is that right, and trustworthy, right? And after that, you specially ask about the onset of the. So what is the first thing? We have to ask certain questions. Write down question number 1. You have to ask yourself questions related with the patient. What is question number 1? This seizure is a true seizure or pseudo-seizure? This is the first thing. Is it really epilepsy or not? This is the very first question which should come to your mind. Because many things which appear as seizure may not be seizure. Everything which twitches is not seizure. Dr. Saab, am I right? Everything twitching is not seizure. Is that right? So first thing is that you have to know that is it really epilepsy or not? Is it true seizure or pseudo-seizure? Pseudo-seizures are psychological reasons leading to seizure-like conditions. Usually these are more common in boys or girls? Why? This is girls have better ways to get attention. This is a pathological way, yes. Okay, sexual abuse in childhood is more common with girls or boys? With girls. Actually, most of the females who develop pseudo-seizure, they have, not all of them of course, they will kill me, most of them have history of sexual abuse in their childhood, either they remember it or not, right? So anyway, so pseudo-seizures are basically seizure-like conditions but which are not due to abnormal electrical activity in the central nervous system. Write down the definition of pseudo-seizure. You know, if you want to be a good doctor, the first step is just to know the person who has come with seizure, is it true seizure or it is pseudo-seizure, right? As I told you last time, it's very important not to overdiagnose or underdiagnose epilepsy, because if you wrongly overdiagnose epilepsy, it means you are committing the person to anti-epileptic drugs for a long time with a lot of side effects, unwanted drugs. Secondly, you may be leading to a diagnosis which is leading to social stigmatization. Then it has implications in social life, it has implications in occupations, it has implications in driving and machine operating and so many things. Is that right? So due to that reason, a good doctor must know how to differentiate between a true seizure and pseudo-seizure. Of course, there are so many types of true seizures and there are so many types of pseudo-seizure. We cannot right now discuss all of them, but just few most important points. For example, okay, I will give you 4 features in the history and you have to tell me which is the most suggestive of a true seizure, right? There are 4 clinical presentations. Patient has a history of tongue biting, especially in the side of tongue, his own tongue I mean. A. B. Patient has history of, during the seizure, he develops urinary incontinence. Third is, during the seizure, patient develop arcing of the back. Muscles become very stiff and arcing of the back. Number 4, during the seizures, limbs move in a flailing fashion, randomly. E, when you try to open up the eyes, patient resists, especially during the seizure, right? Eye opening, resisted during, yes, so during seizure, or eyeballs roll upward when you try to forcefully open the eyes, right? What is the most suggestive of that it must be a true seizure? Just raise your hand, don't comment. Out of these 5 things, there's one thing, if it is there, it must be seizure. Very high chance it must be seizure. Yes? G? A. Tongue biting. Yes. What about you? Okay. People who believe that A is the most suggestive, raise their hands. Okay. Some people who have answered different than this. Yes. Urinary incontinence is not related with the seizure. It may or may not be. Remember, right answer is very right. The right answer is A. Because when you are psychologically playing the game of seizure, you don't cut your own tongue. It's really painful, especially side of the tongue. You do not crush your side of the tongue. Is that right? But when you are psychologically disturbed and you are producing some sort of, passing through some sort of pseudo-seizure, you may develop urinary incontinence. Urinary incontinence may be part of true seizure or may be a part of pseudo-seizure. Arcing of back is unlikely in seizure. It is more common in hysterical problems or other. Limbs flail movement. This is again pseudo-seizures, right? Eyes opening resistance. Of course, during some seizure, if patient has closed eyes and you try to open and he resists the opening or eyeballs roll up, right? Again, it is pseudo-seizure. And there are many other ways to differentiate. But anyway, your question number 1 is when patient comes, you must be able to differentiate, is it a true seizure or is it a pseudo-seizure? Is that right? Question of pseudo-seizure also arises at another stage of management of the patient. What is that stage? First stage is just patient came. A good doctor must be able to differentiate, is it pseudo-seizure or true seizure? All cases cannot be differentiated. There are some very borderline cases, and of course, some unfortunate patient get both seizures. It's quite possible person has epilepsy, along with that she has some mental stress and she develops pseudo-seizure as well. Is that right? So, at other stage of diagnosis also, you start thinking about the pseudo-seizure. When you have tried every drug and seizures are not controlled, you think of pseudo-seizure. Is that right? Again, review your diagnosis. The question is that if you have made a diagnosis and you have tried first drug, second drug, third drug, and it's very difficult to control the seizures, think of it may be pseudo-seizure. Another important thing about pseudo-seizure is usually these seizures occur when there's a chance that there will be people around it and notice it. For example, pseudo-seizure don't occur during sleep. True seizure may occur. Anyway, we will not go into much detail of that. What I was saying, the very first question when a patient of epilepsy come to you, is it true? Is it really epilepsy or not? Is it really epilepsy or not? Let's suppose someone had only one seizure attack. Is it epilepsy or not? It may or may not be. Yes, that's right. It may or may not be. It may or may not be. So it means person who develop one seizure, only one seizure. Do you think we need to investigate the patient? Yes? Yes. Write it down. One seizure is enough to warrant investigations. But you should not label the patient epileptic patient. Is that right? But it does not mean you should not investigate the patient. You must. Right? The first thing. We'll talk about that. So first question is it really epilepsy or not? The second question is, if it is epilepsy, yes, is it partial or generalized? The second question is, if it is really epilepsy, is it partial or generalized? Why this question is important? Because first line drug in partial epilepsy is different and generalized epilepsy is different. What is the first line drug in partial epilepsy? Yes, Dr. Alim. No. Carbamazepine. I always remember, people with partial epilepsy are moving in cars. Very bad. Their license should be cancelled. Is that true? But anyway, in Pakistan, many people with partial epilepsy are moving in car. But you cannot drive the car when you have generalized epilepsy. So partial epilepsy has association with carbamazepine, right? So why it is so important to decide that is it partial epilepsy or generalized epilepsy, because first line drug is different. In partial epilepsy, first line drug is carbamazepine. And in general, what is the second line drug here? What is the second line drug? There are so many, but valproic acid should be put there. Put down a slide, make a box and put a small information in that. Most broad spectrum anti-epileptic drug is. Most broad spectrum anti-epileptic drug is. Anyone from the first row? Yes, please. What is the most broad spectrum? Because it will, this drug will help you in future. If you cannot make the right diagnosis, what kind of epilepsy is there, but you suspect there is epilepsy, you can start treatment with that. Most broad spectrum anti-epileptic drug, hold on, which can control partial epilepsis, which can control generalized tonic-clonic epilepsy, which can control generalized absence epilepsy, which can control myoclonic epilepsy. Yeah. Valproic acid, sodium valproate, right? Most broad spectrum, yeah, most broad spectrum anti-epileptic drug is valproic acid, right? Now, write it down with it, and either it is first line drug for every case or it is second line drug. Either it is first line drug or it is second line drug, valproic acid. Is that right? Either it is first line drug or it is second line drug. Am I clear? And there are other second line as well. In this particular case, in partial epilepsy, carbamazepine is, yes please, first line. And what is second line? Valproic acid. And in generalized tonic-clonic epilepsy, what is the first line? Valproic acid, very good. And what is the second line? Lamotrigine. Is that right? And there are many others as well. But you need to remember at least one first line, one second line. Okay. Then there is another epilepsy we will very soon talk about, absence epilepsy. Generalized absence epilepsy. I will go into detail later. What is the first line drug for that? Yeah. Ethosuximide. Excellent. Ethosuximide. What is the second line? Valproic acid again. Any epilepsy, talk about valproic acid either as a first line or second line. Valproic acid only fail in pseudo-seizures. Is that right? Because they are not seizures. So what is happening there? That if patient come with partial epilepsy, which is your first drug, they are moving in cars. So carbamazepine. And if patient come with the second line drug is valproic acid. And tonic-clonic, generalized tonic-clonic epilepsy, what is that? Valproic acid first line and lamotrigine is second line, and many others are there. In case of absence seizure, I will explain what they are. The first line is ethosuximide and second line is valproic acid. Excellent. And now I come to interesting situation. You have heard of myoclonic epilepsy? I told you last time, flying saucer epilepsy, suddenly some muscles jerk. Is that right? Myoclonic epilepsy. What is the first line drug there? Valproic acid. Excellent. But I'm not interested in first line drug. What is the second line drug? Yes. You can get 10 rupees prize if you can tell me. Okay, just give a chance to Fatma. Yes. Question is, hold on, that in case of myoclonic epilepsy, of course first line drug is valproic acid. If you fail on that, what is the second line? She is not getting 10 rupees. You want to get 10 rupees? Yes, please. Clonazepam, that's good. So 10 rupees you have? Okay, give her later on. Right? Okay, give me right now. I should give her. So next time I'll be doing this thing. It's a very easy thing, you know. You don't need to carry money around. So that is clonazepam. Yes, please. Yes, you can receive it. And remember, write on it 100 times clonazepam. Yeah? I will write it later, right? Okay. But at least you receive it. It is not equivalent to $10 for the people who are seeing the recording. Maybe they become excited by this price. It is just 10 rupees. Okay. Now, listen. Again, let me repeat, it is worth repeating. Valproic acid is one of the most broadest spectrum anti-epileptic drug. Is that right? And Okay, I was knowing how people are answering. Some books are open, that's good. Some authors agree with me, right? So what we are talking about, first line drug in case of partial epilepsy was carbamazepine and second was valproate. And in case of generalized tonic-clonic, valproic acid and then lamotrigine. If partial becoming generalized, again valproic acid and lamotrigine. Partial becoming generalized. Then we come myoclonic. First was valproic acid and clonazepam. And in case of absence seizure, first line was ethosuximide and second line was valproate. Okay. And status epilepticus, first line drug. Yes, diazepam or lorazepam. Better lorazepam. You know why? Lorazepam has, look, generally diazepam is a very long acting drug because its metabolites are also active. But diazepam capability to suppress the status epilepticus is for short duration. And lorazepam ability to suppress the status epilepticus is longer. So lorazepam is, if available, preferred over diazepam. So first line drug in case of status is diazepam or lorazepam, benzodiazepines, bolus. You give a IV bolus, of course. Very good. Okay, I'm coming to you again. You have to win 1 rupee more, hypothetically. Already lost 10. So what I was taking that in this case, for example, someone has status epilepticus. You must be knowing what is status epilepticus. When someone has a continuous seizure or seizure attack in which in between the attack patient does not regains complete consciousness. For example, she gets the fits right now and after 3 minutes she again develops the fits, but in between the two fits she does not regain consciousness up to normal level. This type of seizure in which either there is very prolonged seizure or there is multiple seizures in between which you don't regain consciousness, right? This is called status epilepticus. It's a medical emergency because it should be very aggressively treated. Time is everything, because as duration of status epilepticus become longer, chance of death or chance of permanent brain damage progressively increases. The risk of death or risk of permanent brain damage progressively increases. So in status epilepticus, you should be knowing the drugs very well. First drug was, you have used diazepam or lorazepam. What is the second? Let's suppose you have given diazepam or lorazepam, patient could not really, you can say status epilepticus could not be aborted. It continues. What is your second step? Yes? No, continue the slow infusion, IV. First you give bolus of the lorazepam, then you run the slow infusion IV and take few more minutes. But before the 10 minutes pass, you must go for phenytoin sodium. But intelligent student will tell me not phenytoin sodium, they will tell me something else. What is preferred over? Now phenobarbital. Doctor, what is preferred over phenytoin in case of intravenous treatment? Very good, fosphenytoin. Why fosphenytoin is superior? Dr. Saab is going to tell us why. Listen, phenytoin sodium is excellent, but when you are giving intravenously, we prefer fosphenytoin or phosphophenytoin. Why we prefer it? Because it moves fastly?
Probably because it has higher bioavailability in the body.
No, it's a pro-drug and it need to be converted. Rather it will have low bioavailability, that is why its dose is more than, its equivalents are more than. Yes? No, both of them have cardiotoxicity, my friend. No, listen. Both of them have cardiotoxicity, both of them are sodium channel blockers, and actually phosphophenytoin convert in the body into phenytoin. This is not the answer. Oh, no, 20 rupees is a fine, right? Listen carefully. My question is very simple. Ideally, if patient with benzodiazepine could not be controlled intravenously, and around 10 minutes, you must immediately arrange phenytoin or phosphophenytoin. Any one of these. If both are available, you will prefer intravenously phosphophenytoin. What is the reason? Anyone? Price is again 10 rupees. I saw she has one more 10 rupee. Yes? No one knows it. Yeah? Phenytoin with phosphate is there. Remember, phenytoin sodium is irritant to the vein. It's so simple. Produces a lot of thrombophlebitis and later on even sclerosis of veins sometime, because phenytoin sodium you need to load and then sometimes you have to give intravenous infusion. Phosphophenytoin is not that much fussy with the veins. Write it down. Phosphophenytoin is not that much fussy with the veins. Then it does not irritate the veins so much. Anyway, so second line was your phenytoin sodium. Okay, in status epilepticus, if you have given, of course, let me tell you that when patient come, how you manage. When a patient is continuous epilepsy, for example, tonic-clonic epilepsy, of course, the very first thing is, no, before that, secure airway. Don't give oxygen to a person whose airway is blocked, I hope, or you will give oxygen intravenously, right? So, first thing is secure airway. Secure airway, right? Either you don't go directly for intubation, you can just pass, yeah, there are plastic airways, either nasally or orally, right? First of all, you open or keep the airway open. This is the first thing, and then you give high concentration oxygen. Is that right? Why oxygen is required in tonic-clonic? Because in tonic phase, person is not breathing well. When these respiratory muscles are in tonic phase, he is not breathing well. Even in clonic phase, there are not proper breathing pattern, so we need oxygen extra. You have given what? As soon as patient came, right? In status epilepticus, you have secured the airway, you have started giving the oxygen, you ask someone to draw the blood so that you can investigate later. Then what you do? Then you pass IV bolus, benzodiazepines, as lorazepam or diazepam, IV bolus, then slow IV infusion of benzodiazepines, right? Let's suppose still patient is not settled, you go for phosphonatine, right? First you load and then slow infusion. I will not go into doses, they are written in book, right? So what you have to do? Phenytoin sodium. Usually we say phenytoin sodium should not be given to females. So if a female is brought in status epilepticus, will you give the phenytoin sodium to her?
Yes, we can.
Will you give?
If it's the only thing available. Yes, we can.
Why? There is no other drug available. And you know why females normally should avoid phenytoin? That is why she is talking like this. She is not knowing. Write it down on one corner on the notes separately. Write it down. Phenytoin not for females. How you remember it? Phenytoin not for females. Why? It produces a lot of side effects which are really troublesome in females. For example, female develop ataxia, she developed nystagmus, she developed dysarthria. Do you think you love a female who has ataxic gait with dysarthria, as if she is having a drunken situation and her eyes are showing nystagmus? Females are very sensitive about their presentation, is that right? Even though male also may develop these things, but females are more sensitive to this thing. Is that right? So these are first thing. Write it down on the side. All anti-epileptic drug, almost all, develop these three side effects. But phenytoin produces very severely these side effects. Phenytoin produces very severely these side effects. Right? What are these side effects? Ataxia. Why? Because all anti-epileptic drug inhibit the neuroconduction or neurotransmission. And neuroconduction and neurotransmission is very rapidly required for cerebral functions. So all of them disturb the ascending pathways, dorsal ascending pathways or cerebral connections. Due to that reason, almost all the anti-epileptic drug in their toxicity or side effect produce nystagmus, dysarthria and ataxia. And phenytoin produces this problem more often, number one. Number two, phenytoin when it is taken for chronically, it produces coarsening of facial features. You know, already females work a lot to enhance their facial features in an appropriate fashion. Big companies are helping them. Right? In all the makeup is what? The game of illusion creation, isn't it? Now, if a female is taking phenytoin for a long time, she will develop facial coarsening. Her face will become like yours. So naturally, female don't want a face like that for their own self, right? So they want some refined with chotai art, right? Now, so what I'm talking about, that coarsening of facial feature. Then another problem with the females. Hirsutism, yes. not only face become heavy and boggy, it even looks like men. It produces phenytoin, sodium produces, chronically used will produce hirsutism. Is it not enough for female? Hold on. Just hold. Then in chronic use, there are other troubles. Phenytoin chronically used lead to gingival hyperplasia. Right? Do you think a female whose gums are totally enveloping her teeth and when she smiles then all the guests run away, including the would-be mother-in-law? No female will like that situation. Is that true? So gingival hyperplasia, coarsening of the face, you just imagine there are a lot of guests and parents have put or unfortunately doctor has put a young female on phenytoin and she entered into room with tea and she's having ataxia and dysarthria and nystagmus and facial features are coarsening, and when she smiles, yes, gingival hyperplasia, and problems don't stop there. If somehow she gets married, after the marriage problems will start. First of all, we decide, okay, she go for courtship. It's not in some Western country, she goes for courtship first. And she put herself on the oral pills. Phenytoin and carbamazepine are not good for female. Why? They induce the enzymes which handle the oral pills. So oral pills will be catabolized slowly or fastly? Fastly. And she will become pregnant inadvertently. Right? Again, not for female. Right? Because males usually don't take oral pills. So this problem is not with the male with the phenytoin. Then any other problem with the female? Oh, okay. If she really gets pregnant, then there's a trouble. Phenytoin is severely toxic to the products of conception. It has a teratogenic effect, right? Hayden-Toyne syndrome, isn't it? Baby may develop a lot of troubles. Then phenytoin produces disturbance in handling of folic acid and B12. So there are megaloblastic anemias, macrocytic megaloblastic anemias. Of course, females again have already a natural tendency to develop anemia more readily. At the top, you give her phenytoin. Then, of course, it disturbs the vitamin D function, osteomalacia risk, not osteoporosis, osteomalacia, Dr. Saab. So, osteomalacia. Now, you see, there's so many things which are going against a female. That female develop ataxia, nystagmus, yes? Yeah? Coarsening of facial features, gingival hyperplasia, hirsutism, megaloblastic anemias, osteomalacia, right? There's so many problems. So phenytoin not for females, but write down. But still it is used in status epilepticus because of course their use is not chronic. And it's important to save the life because one shot of phenytoin is not going to develop, you can say, gingival hyperplasia, am I right? And one shot is not going to develop all facial coarsening. Secondly, even females agree it's more important to survive than having a refined face. Yes?
Sir, what phenytoin cause the side effects in males?
It does produce side effects in males, some of them. Right? For example, it can produce to the male ataxia or other nystagmus and other problems. Right? For that, we'll reduce the dose. But females are very intolerant to these things. Is that right? Then you can say males will also develop some other side effect like megaloblastic anemia, but less often because their anemic tendency is less. Of course, males usually don't get pregnant. So product of conception won't suffer in males, right? And in the same way, males don't have, you can say, oral pills problem. So they will not become unexpectedly pregnant. Is that right? Now, so what I was highlighting that in status epilepticus, first step is admit the patient, of course. Before you can say secure the airway, give the oxygen, make the patient in semi-prone position, is that right? Load the patient with IV, benzodiazepines, then with slow infusion. If still not controlled, you go for what? A phosphophenytoin. Most of the patient by this time will be controlled, but some unfortunately may not be controlled, even with phosphophenytoin. And if a patient is still not controlled with phosphophenytoin, what is the next choice? Yeah? Yeah? No, before that you try something. Phenobarbital. Some people try phenobarbital. Is that right? You try phenobarbital or valproic acid. Of course, parenterally. phenobarbital, right? So first give benzodiazepines, then give phenytoin, and then go to barbital. Phenobarbital, right? So phenobarbital, of course, barbiturate. If phenobarbital does not work, then you do what? Then you have to go for general anesthesia. Write down a basic principle. No good doctor should no good doctor should stay on the bedside of a patient with status epilepticus more than 20 minutes without having arrangement of general anesthetist. No good doctor should stay on the bedside of the patient with refractory status epilepticus which has not been yet controlled more than 20 minutes. Within 20 minutes there should be general anesthetist, right? So you can give general anesthesia and then ventilate the patient, right? So all the muscles get relaxed and CNS activity goes really very much down. Yes, you give general anesthesia by which way? Number one, some people introduce barbiturate coma. To introduce the barbiturate coma, which drug is used? Barbiturate coma. Which drug is used? Please tell me sodium thiopental. Thiopental, but you have to give it repeatedly because it's a short duration of action. Am I right? So sodium thiopental, barbiturate. Or you give general anesthesia by, what is the other choice? Which general anesthesia you will give? Yeah. You will give him halothane or what? Or nitrous oxide? None of them. Propofol preferred these days. IV, not inhalation. Propofol. P-R-O-P-O, propofol. Propofol. How propofol works? Okay, who knows the mechanism of propofol? Hurry up. No one knows it. It's very sad. It means I need to tell you that how these drugs work. It's very sad. Who knows the mechanism of propofol? It is cation deloader. Write it down. Look, when you want to inhibit a neuron, what you do? Either reduce the cation loading or increase the anion loading, or it's so simple. You see, this is a neuronal circuit and you want to inhibit this neuronal circuit. What are the ways? Number one, you know what stimulates the neurons? Sodium and calcium influx. Cation loading. When cations go into neurons, they take the resting minimum potential to threshold. Right? Look, sodium and calcium stimulate the neurons. The cation which is inside is which one? Potassium. And anion which is outside is which one? Chloride. That's so simple. I don't know how to tell you. It's so simple that all the anti-epileptic drugs should have one or more than one of these mechanisms. Either reduce the cation loading. All anti-epileptic drugs should reduce either sodium or calcium loading, right? Or increase the chloride loading, or increase the chloride loading, or increase the cation deloading. It's so simple. When you want to inhibit a neuronal circuit, what you do? Either don't allow the cations to go in so that it does not get depolarized. So prevent the sodium influx or calcium influx. Or you bring the internal cations out. Produce potassium efflux. Produce potassium efflux. Or to make the neuron very hyperpolarized, very electronegative when you bring the cations out. Or load the neuron with anions. You will load it with what? Chloride. Am I clear? Okay, now you will tell me which anti-epileptic drugs are preventing the cation loading. Which are sodium loader preventer? Write it down. Anti-epileptic drug which prevent the sodium loading mainly. Please tell me first of all phenytoin. Number 2 is carbamazepine. Number 3 is valproic acid. Number 4 is lamotrigine, and there are so many others, but at least these 4. They prevent the sodium loading. Can you tell me a drug which prevents the calcium loading in the neurons? especially in the thalamic neurons. Yes, please. Very good. Abidocyan is these days active. Ethosuxamide. So look here. What are these drugs? These are 3 drugs which prevent the what they prevent? Sodium influx. And what are these drugs? Yes, please. Phenytoin. Then there is carbamazepine, and then there is valproic acid. Then there is calcium influx. There is a drug which prevents the calcium influx. It does not allow the calcium to go in. What is this drug? Ethosuxamide. You must be knowing it's the master drug for absence epilepsy, right? Then there are potassium deloaders. What is potassium deloader? Classically, about if I tell you valproic acid, that acts by all ways. Valproic acid prevents sodium loading. Valproic acid prevent calcium loading. Valproic acid enhances potassium deloading. Valproic acid increases chloride influx. Valproic acid acts by all ways, all means. That is why it's such a broad spectrum anti-epileptic. But action of valproic acid at different concentration are different. If you give the patient valproic acid, it blocks the sodium influx, it blocks the calcium influx. It means it prevents the depolarization. At the top, valproic acid brings a lot of potassium out, so make the neurons very much electronegative. So you make the resting membrane potential much away from threshold. So what you are doing? If it was minus 90, when a lot of potassium has come out, it becomes minus 110. So it becomes very difficult to take the resting membrane potential up to threshold. At the top, sodium and calcium are not allowed to go in. At the top, valproic acid at high concentration inhibit the enzyme which destroy GABA. Valproic acid in high concentration inhibit the enzyme which destroy GABA, which means valproic acid increases the action of GABA. Valproic acid increases the action of GABA. It means when GABA work more, gamma-aminobutyric acid, it will lead to more chloride loading and more potassium deloading. So it means valproic acid in high concentration can increase the chloride load and increase the potassium deload. Now you imagine what really happens with valproic acid. If it was minus 90 millivolt resting membrane potential, number one, it will take the potassium out and bring the chloride in. So resting membrane potential become very, very negative. At the top, it will prevent the cations to go in. So very negative resting membrane potential cannot be pulled back to threshold and neurons cannot be stimulated. So valproic acid is master in these things, that it works by multiple actions, and because it works by multiple actions, we can give it less dose. Multi-action drug, we can give it less dose, so it has less side effect. That is why if a person is, let's suppose a young lady come to you and she says she is running a computer business, she is computer programmer and she has epilepsy, which drug will you give? Someone is a computer programmer and having epilepsy. Can you give her phenytoin? Not. You cannot give even carbamazepine, which produces sedation. Phenytoin also produces sedation and many other unwanted things. Most of the anti-epileptic drug produce sedation. The minimum sedation is produced by valproic acid. Right? Let's have a break.